Good evening. I would like to welcome our audience, both from Malaysia and India, to this inaugural joint webinar. And for the first webinar between ICS and MTS, we choose the topic of changing paradigm of asthma, what it means to your clinical practice. I'm Prof. Izwan Ismail. I'm the president of the Malaysian Thoracic Society. And with us this evening, we will have two speakers. The first speaker is Dr. Rajada, the current secretary of the Indian Chest Society, followed by Dr. Azhar Omar, who is the current head of Special Interest Group, Asthma, of the Malaysian Thoracic Society. The last 30 minutes or so, it will be live discussion. It will be moderated by Dr. Sundip Salvi, who is the president of the Indian Chest Society. And he will have 4 panelists to talk about asthma. So our first speaker this evening is none other than Dr. Rajada, who is the current secretary of Indian Chest Society. He is the current director and head of department of the pulmonology at C.K. Birla Hospital in Calcutta. He spent his early years doing training in the UK and returned back to India in 2008, where he took up the post of Director Education and Research at the National Allergy, Asthma and Bronchitis Institute in Calcutta. Just prior to the recent appointment, he was the consultant pulmonologist, intensivist, and coordinator at the Department of Pulmonology and Critical Care at Fortis Hospital, Calcutta, for almost 10 years. So this evening is going to talk on the topic of mild asthma. How has the change guideline been reflected in clinical practice? Without further ado, I would like to invite Dr. Rajada for his talk.
Hello, friends. My name is Dr. Rajadhar, and I'm the Secretary of the Indian Chest Society. I work as a consultant pulmonologist and head of department at the C.K. Birla Group of Hospitals, which is located in Kolkata, a city in the eastern part of India. Heartfelt thanks to the Malaysian Thoracic Society for collaborating with the Indian Chest Society on the first ever webinar between the two countries. These collaborations add a lot of value to academics across countries. There are also CPD accreditations for this meeting across both countries, and I hope this is the first of many collaborative meetings that we do going forward. My ambit today is to speak about mild asthma. Over the next 20 minutes, I'm going to talk to you about various facets, updating you about what's happening in this space, and I'll try and put things in clinical practice, in a clinical perspective, and how it should impact your clinical practice. All of you know that asthma is one of the most common chronic diseases worldwide, with an amazing 358 million people affected from this chronic disease. It causes a lot of morbidity worldwide. India has about 37.9 million asthma patients, which is about 12% of the global population. Asthma management is a challenge in India because the largest mortality from this disease is also in India, with 42 out of 100 people who die from asthma being from India. The Malaysian numbers are better, but I think there's a lot we can do in treating this disease well, and that, of course, starts with the management of mild asthma and then goes on to the management of severe asthma. I start off with this lovely study which came out from Ian Pavard's group and got published in The Lancet in 2018. We have divided asthma into 2 different eras. The era which went on till about 1990, when people thought that this was a disease of bronchoconstriction, of airway remodeling, airway narrowing. And then post 1988, we have known that this is a disease of inflammation. I know this doesn't project well, but I hope you can see my cursor. What we are looking at is the asthma mortality rate per 100,000 individuals. And you can see there are large peaks of mortality throughout the bronchodilator era. So bronchodilation, even proper use of these drugs, be that oral or be that inhaled as it was during that era, resulted in significant deaths. And then I want you to look at the right, the inflammation era, starting from 1988 and 1990 onwards and moving forward. You can see these peaks have gradually grown smaller. The numbers have reduced, and hence starting use of inhaled corticosteroid as the most potent anti-inflammatory has resulted in reduction of mortality across the globe. We often perceive of any mild disease as a disease where there should not be a lot of focus. We feel mild disease does not cause symptoms. It does not cause exacerbations. It does not cause deaths. This is, however, not at all true in patients with asthma. So if we try and define mild asthma, and this is something which Gina has come out with in the not so distant past, they've defined mild asthma as asthma that's well controlled with low intensity treatment. And low intensity treatment is defined as low dose inhaled corticosteroid, formoterol, or low dose ICS plus as needed SABA. So the definition of mild asthma is defined by the amount of drug used rather than the symptoms that you have or the exacerbations that you have. And that, you might argue, reduces the gravity of this disease process. So what's the gravity then? So these are numbers for you to remember. Patients with mild asthma are very much at risk of serious adverse events. So more than a third of patients will have acute asthma. More than a seventh of patients will have a near fatal attack of asthma. So that's 16%. That's a large number. And 15 to 20% of adults who die of asthma actually have a background of mild asthma. So a third of patients with acute asthma, 1/7 of patients with a near fatal attack of asthma, and 1 out of 5 patients, adults dying of asthma, have a background of mild asthma. Exacerbation triggers for mild asthma is unpredictable. It's more unpredictable than what it is for severe asthma. It could be viruses, pollens, pollution, poor adherence, or it could be a combination of these factors. Inhaled short-acting beta agonists have been first-line treatment of asthma for more than 50 years. That's what I studied in my medical school. Give people a puff of salbutamol, the symptoms go away. The other reason why people feel this is good for you even today is because taking a puff of this cheap inhaler makes your symptoms go away almost immediately. So the relief is immediate. And starting treatment with SABA gives people quick relief, and people start perceiving, patients with asthma start perceiving the short-acting beta agonist as being their primary treatment for the management of asthma. The use of anti-inflammatory therapy, the inhaled corticosteroid, hence goes for a toss in individuals where SABA is considered first line. So what is the problem? Why would we worry if SABA becomes the first line management of patients? So we've learned in the last 7 to 8 years that use of SABA, even for a total of 1 to 2 weeks, is associated with adverse effects. It's associated with adverse clinical outcomes. People have tried to standardize the amount of use that causes harm in case of SABA. So dispensing more than 3 canisters per year increases the risk of exacerbations. If you're using about 1 canister a month, so more than 12 canisters per year, there's a much higher risk of death in individuals. And we've actually known this for the better part of 30 years. Inhaled corticosteroid, on the other hand, reduce the risk of deaths, hospitalizations, and exacerbations that require oral corticosteroids. However, the challenge with inhaled corticosteroid paradoxically is that adherence is poor, particularly in patients with mild or infrequent symptoms. So why not treat with a SABA alone? So people with apparently mild asthma, like we've just said, also have severe or fatal exacerbations in not insignificant numbers. We have said that the exacerbation triggers are unpredictable. If you keep having oral corticosteroids as opposed to the inhaled, your risk of osteoporosis, diabetes, cataract, all of these increase significantly. And the way to keep down the course of oral steroids is by adhering to your inhaled corticosteroid. So 2 weeks, we said, use of SABA for 1 or 2 weeks increases your risk of exacerbation. How that happens is by increasing airway hyperresponsiveness. Your airways become more twitchy if you use the SABA frequently. It reduces the bronchodilator effect of the SABA reduces. There's increased allergic response and there's increased eosinophils. And all of you know increased eosinophils translates into greater number of exacerbations. We said, and it's important to reiterate, that starting with a SABA trains your patient. That's the primary asthma management. It gives you immediate relief. So taking as and when required SABA, which we now know is bad for you, increases the chances that the patient keeps using this inhaler only. The only previous alternative was daily ICS, even when there were no symptoms, and this had poor adherence. So people don't want to take an ICS on a daily basis if they have no symptoms, and hence GINA changed its recommendation once we had safe and effective alternative available. And we'll discuss about the alternative in a moment. Now, before we go into what the alternative is, this is lovely data, and again, about 24 years ago, data which shows that regular use of ICS is associated with the decreased risk of death due to asthma. So you can see the number of canisters of inhaled corticosteroids per year being mapped out there, and the rate ratio for death for asthma being mapped here. And you can see as the number of canisters go up, so for people who use 1 canister a month, which is what they're supposed to do, their rate ratio for death from asthma is almost 0. So this is a disease that can be treated so effectively that the mortality comes down to almost 0. This is it's a slide which lists out the goals for asthma management in patients. So the 5 goals for asthma management according to GINA is to achieve and maintain control of symptoms, maintain normal activity levels, maintain lung function as close to normal levels as possible, prevent exacerbations, prevent asthma mortality, and avoid adverse effect from asthma medications. You can see out of those 5, 3 and 4 are highlighted in red. And that's because those are the 2 most important ones which result in mortality and morbidity, preventing exacerbations and preventing asthma mortality. Inhaled corticosteroids reduces both these endpoints. It prevents asthma exacerbations, it prevents asthma mortality. Using a SABA, on the other hand, that does just the reverse. It increases exacerbation, it increases mortality in patients. So do you use the inhaled corticosteroid by itself? You wouldn't, because the airway inflammation also results in the narrowing of the airway. It results in bronchoconstriction. So it makes sense to use the ICS and the long-acting beta agonist together. Adding an ICS to a LABA, of course, has additive effects, but this slide shows you that it also has synergistic effects. So you can see the effect of the LABA, the effect on the mast cell, on bronchoconstriction, on the reducing plasma leak, and reducing sensory nerve activation. All of those factors together result in the bronchodilation that the LABA causes. Look at the inhaled corticosteroid on the other hand. It works on various inflammatory cells, so the macrophage, the eosinophil, the dendritic cells, etc. This reduces airway hyperresponsiveness. So when I say this, I mean the inhaled corticosteroid reduces airway hyperresponsiveness, and it reduces the inflammatory cells which trigger the inflammatory cascade of asthma. So when you add a LABA and an ICS, the LABA works on the cell membrane. So the beta-2 agonist receptor is on the cell membrane. It goes and binds and causes bronchodilation. The inhaled corticosteroid goes into the cell, and it is located on the various cells that is shown in the figure on the left. So binding to the glucocorticoid receptor, it exercises its anti-inflammatory effect. However, important on this slide, the glucocorticoid receptor with the inhaled corticosteroid bound to it provides a positive feedback to the beta-2 receptor where the LABA is binding, and the beta-2 receptor, on the other hand, with the LABA provides a positive feedback to the glucocorticoid receptor and hence increases the anti-inflammatory effect of the inhaled corticosteroid. So 1 plus 1 here does not equal to 2. 1 plus 1 here equals to 3. It's the synergistic effect which increases the benefit of a LABA and an ICS put together. So I told you the reason people use SABA is because they get instant relief. One of the challenges we had previously was the LABA seemed to take a while for the drug to act. Hence, patients did not perceive the benefit immediately, which is what they wanted. However, with formoterol, we have a LABA where the onset of action is very similar to that of a SABA. So combining the formoterol with an inhaled corticosteroid, which also has a quick onset of effect, and here you've got two inhaled corticosteroids that we talk about, budesonide and beclomethasone. So combining the formoterol to either budesonide or beclomethasone results in effective bronchodilation and anti-inflammatory effect. But more importantly, the onset of action of the drug is quick. The patient gets quick relief, which is what they want. Keeping all of these factors in mind, GINA has revised its guidelines from 2019 onwards. So it's gradually undergone evolution. And what you see in front of you now is the 2023 guidelines. So step 1 and step 2 of the preferred track, and you can see there are two tracks here. One is the preferred track at the top, and then you have the alternative track at the bottom. In the preferred track, the controller and the reliever medication are the same. So as and when needed, ICS plus formoterol, and we've said here the ICS is budesonide or beclomethasone. So as and when needed, low dose ICS plus formoterol for step 1 and 2. In step 3, you have maintenance ICS formoterol. In step 4, you have medium dose maintenance ICS formoterol. And in step 5, you need to phenotype the patients. You've got options like using a LABA, using a low dose macrolide, or phenotyping these patients to decide which biologic you prescribe. And there's a separate talk to address this. So what you want to see is the red square at the bottom. I hope you can see my cursor there. You can see the reliever medication is also an ICS plus a formoterol. So this is what is called single maintenance and reliever therapy. So the ICS formoterol is used for maintenance. It's also used as a reliever. Look at track 2 for me now. In track 2, you have alternative controller. So you've got the controller, which remains the ICS plus formoterol, but the reliever is different. So different maintenance and different reliever. So step 1 is ICS to be taken whenever required along with the SABA. Step 2 is low dose maintenance ICS. Step 3 is low dose maintenance ICS plus LABA. Step 4 is medium or high dose ICS plus LABA. And then you've got step 5, which is similar to what you have in the preferred pathway. Here you see the reliever is as needed SABA, or in countries where it's available, like in India, it's an ICS plus a SABA. So the importance, the emphasis on using ICS with every puff inhaler you take is maintained both in the preferred and in the alternative pathway. The concept of single maintenance and reliever therapy is what is emphasized in track 1. That's what makes it the preferred treatment. So I said in the alternative pathway, you have ICS plus SABA. A lot of countries throughout the world don't have ICS SABA, but will do so in the not so distant future. This is a neat study which looks at a combination of albuterol plus budesonide, combination of these two drugs versus albuterol by itself. This is for use in GINA step 3 to step 5. There are 2 doses of budesonide which are advocated, which is why you have 2 graphs. In one, you have albuterol 180 micrograms plus budesonide 160. And in the second, you have albuterol 180, so the same dose plus budesonide of 80. In both, the probability of a severe exacerbation is significantly greater. The p-value is significant in patients just using albuterol as rescue versus people using albuterol plus budesonide. So even for the alternative pathway, presence of an ICS reduces severe exacerbation significantly. This is a chart from GINA, which looks at some of the new nomenclatures and modifications of the old terminologies. So this maintenance therapy, where asthma treatment is prescribed on a daily basis. And this is fixed irrespective of the burden of symptoms. So the treatment could be an ICS, it could be an ICS plus a LABA, it could be ICS LABA plus LAMA, it could be a leukotriene receptor antagonist, it could be a biologic. All of these forms of treatment can be given regularly to asthmatic subjects. The emphasis is on the word regularly. Then you have controller treatment. Controllers are medications which target both domains of asthma control. So what are the 2 domains? One is symptom control and the other is future risk of asthma. The concept of controller has changed a little bit and it's in the notes there for you to read. Reliever therapy, as has been historically, are drugs which are needed for quick relief of asthma symptoms. So this could be a SABA, it could be an ICS plus a SABA, or it could be an ICS plus a LABA. Traditionally, you would remember relievers used to be a SABA alone. A new nomenclature in the 2023 guidance, something which I think merits emphasis, important for all of us to remember, is this terminology of anti-inflammatory reliever. So anti-inflammatory reliever are inhalers which contains a low dose of ICS and a rapidly acting bronchodilator. So this is what we spoke about a little while ago when we spoke about the concept of maintenance and reliever therapy, single maintenance and reliever therapy. So the reliever inhaler plus the ICS could be a LABA plus an ICS, or it could be a SABA plus an ICS. This is a nomenclature which is here to stay. It lays emphasis on the concept of smart treatment and the fact that ICS should be a part and parcel of every puff of inhaler that gets given to a patient with asthma, irrespective of how mild or how severe their disease is. And then we've spoken at length about MART, which is maintenance and reliever therapy, single inhaler, which is the preferred track of GINA that we spoke about a little while ago. Despite the addition of ICS SABA as a reliever in track 2, for most patients, track 1 is the preferred treatment. So if you ask me, 90% of my patients with asthma today are on GINA track 1. What are the benefits? Why do I prescribe this in 9 out of my 10 patients? So you have the hassle-free experience of using just one inhaler. So single medication for symptom relief and maintenance. Hence, titrating treatment going up or going down on treatment becomes easy by just changing the number of puffs of the inhaler that you need to take. You have an asthma action plan which is easy. rapid increase in both ICS and formoterol relieving symptoms is all you need. As needed formoterol is more effective than SABA in reducing exacerbations. So if you looked at capacity of formoterol to reduce exacerbations versus a SABA in reducing exacerbation, formoterol scores over a SABA in this category. In step 3 to step 5, the weight of evidence for effectiveness and safety of MART versus comparators in a very large cohort showed that use of ICS plus LABA, both for maintenance and reliever, worked better as compared to ICS plus SABA used together. In step 1 and 2, the weight of evidence for effectiveness and safety of as needed ICS formoterol compared to SABA and compared with RCT with the ICS showed that ICS plus LABA scores over both arms. Of course, SABA by itself, but also the inhaled corticosteroid arm. Availability of medications, all you need is a formoterol budesonide or a formoterol beclomethasone inhaler that bails you out in the various steps across GINA. This is a study which looked at low-dose ICS formoterol in mild asthma compared to as needed SABA. This is the famed Sigma trial, and you can see a 64% reduction in the rate of severe exacerbation. That's a whopping number. 64% of patients had a reduction in their asthma exacerbations. Compared with maintenance low-dose ICS, the risk of severe exacerbations was similar or lower in Sigma 1 and 2 compared to the trials when used ICS plus SABA, the novel START, practical studies, etc. There was a small difference in other outcomes favoring maintenance ICS. So remember, this is maintenance ICS versus ICS plus LABA as and when required. So there were small differences in favor of maintenance ICS, but none of them met the criteria for minimal clinically significant difference. So the ACQ mean difference, the FEV1 difference, the FeNO difference were all slightly in favor of using ICS maintenance. However, in these large studies with large numbers of patients, it did not reach clinical significance. The average ICS dose was very low. So the worry that people have of ICS being in the bloodstream and causing systemic side effects is lower because the average ICS dose was as low as 50 to 100 micrograms of budesonide per day. This is a meta-analysis of all 4 RCTs. So this is about 9,500 patients. And this shows a 55% reduction in severe exacerbation compared to SABA alone. And similar risk of severe exacerbations with daily ICS with as and when needed SABA. Emergency visits or hospitalizations were reduced by 65% greater than what SABA did by itself. And it was 37% lower than daily ICS by itself. So the ICS plus formoterol SOS worked better in reducing emergency visits or reducing hospitalizations as compared to daily ICS. And patients having SABA alone had a lower risk of severe exacerbations with as needed ICS formoterol compared with daily ICS plus as needed SABA. So this ticks all the boxes that we have discussed so far. It's always been said by GINA and by other world bodies that you need an action plan. So you have the yellow, the orange, and the red zones. Where you want to be is the yellow zone. The yellow zone is the normal mode. When you have your single maintenance and reliever asthma treatment, your treatment happens regularly on a daily basis, and you have a reliever treatment, which is ideally the same inhaler, or you could have a different inhaler like a SABA ICS, or as a last case scenario, SABA by itself. Then during a flare-up, you just increase the amount of ICS formoterol that you have over a period of time, and the yellow box guides you how to do that. More than 12 budesonide formoterol inhalations in total in any given day, you need to go and see your doctor. So it also lays out the ceiling. It shouldn't go above this level. If it does, go and see your doctor. And the red box obviously is the emergency. If you have an asthma emergency and there are symptoms that all of you know of, symptoms getting worse, difficulty in breathing, and even when you speak, and little or no improvement from budesonide formoterol reliever inhaler, get to the doctor, get an ambulance, try and get to a hospital emergency as early as possible. I'm not a pediatric pulmonologist, but this is just for the sake of completion. The GINA 2023 guidelines recommend the management of asthma in children, which is 6 to 11 years, on lines which are similar to what you have for adults. However, you can see that the reliever inhaler still remains SABA in case of children, because the studies with a SABA ICS or a LABA ICS reliever are far more limited in case of children as compared to what it is for adults. However, you can see that the tilt, even in children, see step 1, low dose ICS taken whenever SABA taken, step 2, low dose ICS daily, and then the step 3, step 4, and step 5 are very similar. So the emphasis remains on starting the ICS as early as possible and not to give a puff of inhaler if possible without the inhaled corticosteroid. So these are my carry home messages for you. SABA monotherapy is bad for you. And that's irrespective of which step of asthma you're treating. It increases morbidity, it increases exacerbations, it increases hospitalization and mortality. I think we have emphasized that any puff of inhaler that you take in asthma, be that in adults or children, should contain an inhaled corticosteroid. We have tried to propagate and promote the concept of SMART, which is single maintenance and reliever therapy. And we have said ICS plus formoterol for maintenance and rescue. And we've talked about 2 inhaled corticosteroids recommended by GINA, which is beclomethasone and budesonide. In step 3 to step 5, other combination inhalers for maintenance can also be used. So it's not as if your salmeterol fluticasone cannot be used or your ultra LABA plus ICS cannot be used, but you would use these in step 3 to step 5, where you need maintenance treatment. The SOS treatment needs to be with a drug which has a fast onset of action. And we've said that formoterol scores over other LABAs in this particular aspect. And last but not the least, the use of ICS reduces the risk of mortality, while the use of ICS increases the risk of morbidity and mortality. Thank you for listening to me. I hope there were some learning points from that particular talk. You will now hear a panel discussion with an elite panel across 2 different countries answering the questions that you have on various facets of asthma. Thank you again from myself. I hope we hear and do these activities much more together across countries going forward. Thank you very much.
Thank you to Dr. Rajada for very enlightening talk. We'll move on to our second session this evening. We're going to have a second lecture from Dr. Azza Omar. She is the respiratory physician at the Hospital Raja Perempuan Zainab in Kelantan, Malaysia, which is at the east coast of Malaysia. She completed her fellowship in respiratory at the various hospitals in Malaysia, with her main interest lies in lung oncology, asthma, and COPD. Dr. Azza Omar is a member of the developing committee for Malaysian CPG asthma and actively involved in both Malaysian Thoracic Society as well as Malaysian Association of Bronchology and Interventional Pulmonology. Her center is probably the most, is the center where most patients receive biology. And for this evening, he's going to talk on severe asthma and the use of biologics, what's happening on the ground. So please, Dr. Azza, your talk.
Thank you, Mr. Chairperson. And I am Azza. I'm from Malaysia. Today, I will be talking about severe asthma and the use of biologics. So what is actually happening on the ground? First and foremost, thank you so much for both MTS and ICS for actually inviting me to talk on this platform, because I think this is a very good start for both countries to actually move forward, to actually prosper and gain knowledge and share knowledge between the two countries. So let us see what is happening actually on the ground. Let us go and look into two case studies first, and I think which we can actually relate to from our daily practice. This is actually a 24-year-old man, non-smoker, who actually works at a supermarket that handles cold storage. He was actually diagnosed asthma since childhood, and history of ventilated for twice for his asthma, and he has allergic rhinitis, and he has allergic to seafood. He had frequent visits to ED for nebulizers prior to the COVID era, and clinically he's not obese and no significant findings. He's actually, his weight is about 60, and his BMI, I forgot to write that, it's about 25. His spirometry, actually, if you can see here, that really doesn't show that much. FEV1 is 0.105, FVC of 100. And if you can see here, quite normal. And for us to get a real finding of a true spirometry of an obstructive airway disease, sometimes difficult. I'm not saying it's wrong, but in this case, there's a possibility that the patient actually had his inhalers before he came for this spirometry testing. So this is actually based on the data that I took. But his FeNO came back as 85 and ranging about 100 to 147. His eosinophils was 550, and his serum IgE was unanimously high. It's about 3,530. He was actually started on beclomethasone formoterol, 2-puff BD and PRN, marked. He was added on LAMA and tab azithromycin 250 milligram OD, and added also a nasal spray. And later on, once we saw that the patient was actually not improving, so we started him on omalizumab in March 2022 with initial of 600 milligram 2 weekly, and now 300 milligram 2 weekly. This is going to be a discussion. This is just real life. And the other case I'm going to present is a 50-year-old man, ex-smoker, about 30 pack years, works as a carpenter, underlying hypertension and hyperlipidemia, and actually diagnosed with asthma in 2014 with persistent shortness of breath and cough. Spirometry at diagnosis showed positive reversibility and had history of 2 times of intubation for his asthma. And further history, he had chronic rhinosinusitis with nasal polyps and eczema. His ACT said during that time was 11/25, and he had strong family history of asthma. And looking at this patient had many missed days of work and medical leaves, frequent attacks, requirements about 1 to 2 times per day, and taking daily OCS and having bursts infrequent. His eosinophils was very high, 1,030. His FeNO was 103. His serum IgE was 1,734. You can see that the spirometry is being shown. So we actually started him on MARC of beclomethasone formoterol, 2-puff BD and PRN, adding on LAMA with other additional medications such as azithromycin, montelukast, as well as mometasone nasal spray and loratadine as well. So this patient, in spite of all this medication, the patient actually did not improve that well. So we started him on subcutaneous omalizumab 300 milligram every 2 weeks. And symptoms improved actually, and no exacerbation or ED visits, and FeNO actually went down to 38. Serum eosinophils actually went down to 20, remarkably, with using an anti-IgE. So with these two cases, as you can see, you may debate and you may question my cases as the first one, which very high IgE as well as eosinophils. So, but this patient only managed to have 3 months of injection, and because of funding. So what comes to us is that all these cases that we find, and I think in Malaysia that we find that cases that which trigger us and are very tricky for us is too high of serum IgE and high serum eosinophils. Patient allergic to a biologic, we had issues on that. Would you change to another biologic? Patient who has asthma who is exposed to smoke, we can consider them as COPD or overlap. Patients requiring daily oral corticosteroids, uncontrolled on biologics, and the role of switching. and which biologic will be the best for the patient, and funding, especially the funding of biologics. So looking at global and national burden of asthma, as you can see, look at this paper in CHEST February 22, even though the burden of asthma has decreased, but there is a large inter-country variability. So what we find is that the prevalence remains high, as do death and the disease itself. So what we find definitely has been repeatedly in lots of papers as well as presentation. Severe asthma consists of actually about 10% of asthma population in the Asia Pacific region. And it actually is nearly the same globally. And we can see it is more in the Central and East Europe. But you have to understand from this, you can find about 3 to 4% of them are refractory severe asthma. So when you look into the ISAR, which I think most of you are well versed about this, they found that most of the patients were which were severe asthma, 34% were already at GINA step 5. And 50% had poorly controlled disease. And 50% of them were regularly receiving intermittent oral corticosteroids. And about 25% of them already were receiving biologics. So this is about nearly about 72% of those who are at GINA step 5. From here, we know that the patient is not controlled. And there you can see that it's predominantly female, and most of them are obese. So what we found in Malaysia, that the latest publication is that what do we find in the model of poor asthma control in adults? As you can see from here, if you notice that patients who had triggering, what triggers asthma is that it's not just simple as allergens, but physical activities, even air conditioning triggers asthma, haze. And you can see that what it was very interesting was that some patients that had poor asthma control, some of them, they looked into what the source of payment in this patient. Why? Because we're talking about patients who we know that it's not just a matter of a disease and the pathophysiology, but what makes it patient becomes control and not control. We have to be realistic. Some patients to the nearest clinic will actually have an effect of how they are going to get proper treatment and proper medication. And as you can see from here, that distance to the nearest health clinic also plays a role. And what we found was that the more patient had emergency visits, the more higher the patients had poorer control. So, and we know that most of them had poor inhaler technique. So this is what we're looking to. We are always looking into, is it the correct medication? Are we giving enough ICS LABA, enough high dose of inhaled corticosteroids? But in actual fact, all these small things, generally we always forget, plays an important role. So basically what we are looking into, what is severe asthma definitely? What do you mean by severe asthma? Severe asthma is actually a subset of a difficult to treat asthma. It's uncontrolled, and we have given the maximum optimized high dose ICS/LABA treatment and management of contributing factors that has worsened when high dose treatment is decreased. So with ATS as well, they show that it requires patients to be in GINA step 4 or 5, or using systemic corticosteroids more than 50% of the previous years, and to prevent it from becoming uncontrolled, and which remains uncontrolled despite of this therapy. So when you look at GINA 2023, you look far to your right, you're looking at step 5. So when you look thoroughly, when we focus on that, it shows that once you have reached step 5, additional of add-on LAMA, and you have to do a proper assessment to look at the phenotype to assess if this patient is truly requiring biologic, which we have to consider a patient who's already on high dose inhale corticosteroids. So from here, the track 1 and track 2, in spite of ICS formoterol or ICS LABA, we have to actually consider the phenotype. And at the other options, we may add on azithromycin, or the last resort is actually a low dose oral corticosteroids, but that should be to consider all the side effects that will have the repercussion of starting on oral corticosteroids. Okay. So when you go through the specialist care, when we have a severe asthma clinic, when it's available, when look into what I've actually highlighted, in GINA 22, we put that as patients in the ground, at the ground level, we tend to have issues in starting medications. So at the last resort, we can actually add on a low dose oral corticosteroids, but to implement strategies to minimize the side effects. And add on treatments like LAMA, low dose azithromycin, and patients, we need to actually consider of anti-IL-4 or anti-TSLP, which later I'll go a bit deeper on that. Okay, as you can see here, I've just emphasized that. All right, so what is actually happening on the ground? What is our expectation and the reality of it? Okay, from here, we actually look into the expectation of reality. We can actually want the glass slipper of all the things, but looking at the assessment of diagnosis of severe asthma, the phenotyping, the severe asthma, the guideline selection of the biologics, and treatable traits of the medication. So when you look at severe asthma, as I said just now, it's just a subset of difficult asthma. You have to look all these factors, which is adherence, inhaler techniques, and triggers and comorbidities, and as well as looking at the is it truly diagnosis of asthma? So I'll go through that a bit deeper. This is a busy slide looking at major asthma, mechanism of asthma and progression. When you have all these allergens and all these exposures, smokes and everything, it triggers a lot of inflammations like interleukin 4, 5, eosinophils, and so on, that causes to hyperactivity, airway hyperactivity, and smooth muscle cells and all these things. So with all this, are we actually reaching to the right treatment? Okay. But in spite of we looking at the pathophysiology and actually targeting and trying our best to look at the treatment itself, we always forget that we have to go back to the ground, which is the primary care. And looking at this, a paper, actually a very good paper from Australia, presented in 2018, looking at what are the barriers to the optimal care in primary care. So when you look here, before a severe asthma referral pathway can be achieved, at the primary care itself, suboptimal use of spirometry. I'm not sure in India, but in Malaysia, not all of our clinics, especially the private clinics, do have a spirometry, and we do not have that. And it's something simple, but still not really used and not well versed with everyone. So under use of guideline directed maintenance therapy, which is always like very, very not being actually bring forward. And forward again, once, let's say, the patient has been referred, the length of waiting list to see us, and the medical access to difficult medical access to rural patients. And this is in Australia, talking about Australia, and I can tell you in Malaysia as well, we have difficulties in assessing specialized allied health. And once we start to see them in the severe asthma clinic, we need to have a multidisciplinary team, and this leads to a limited access to all this, as well as even in selected tertiary centers. And in Malaysia, only a few states that has the severe asthma clinic, and we are actually expanding, hoping in the future that all states with a chest physician will have a severe asthma clinic itself. And assessing not just a chest physician, but the allied health, like a nurse, physiotherapist, a speech therapist, and even a dietitian or clinical psychologist. So the factors contributing to all these symptoms and exacerbation, definitely looking at incorrect inhalers, optimal adherence, comorbidities, modifier risk factors and triggers. not looking at the biologics itself, but you have to look into all this first, and regular overuse of SABA, and even the anxiety, depression, and the medical side effects. So just really roughly going through the disease-related wrong diagnosis, comorbids and phenotypes. So severe asthma mimicus, there's a lot, and I'm not going to go each and every one, which I know everyone will know more about this. But these are the mimicus that we tend to forget. And how about comorbidities? Like cardiac asthma, we can have oral obstructive airway disease, and even COPD, and simple as GERD itself. So all these comorbidities that actually worsen the asthma should be addressed, especially in patients who you think that may have other something else besides asthma itself. And now we are looking into biologics with comorbidities. So it is very important for us to look at the airway-related and airway-unrelated symptoms. This is a busy slide as well. I won't go through it thoroughly. How about phenotypes, which is very, very important. Even in GINA, they emphasize to actually look into phenotypes. So phenotypes in the ISAR, you can see that most of the patients, 88% of patients had elevated biomarkers. And some of them are already related, and some of them can be both having eosinophils and pheno high or IgA high. And even some will have all three high. And these are the patients that we need to understand that how we are going to address this patient, because later on, the biologics that we have in the market actually emphasize only targeting one by phenotype. And even from data from Denmark has similar findings, which is 70% have also elevated biomarkers. So looking into the phenotypes, asthma is heterogeneous. We are focusing so much on the type 2 asthma 1 and non-type 2 asthma, which nowadays the emphasis of the treatment is actually on the type 2 allergic base, which is more severe presence of eosinophils, early age of onset, and it has the atopic or IG component. And the other part which we tend to forget, but is the most difficult to actually address, is the non-type 2, which is obesity-related, late onset of women, and smoking associated with neutrophilic. And this may be debated. Is this COPD or smooth muscle-mediated polygranulocytic? So all these things, you can see that biomarkers, how do you really identify? Is it T2 high or non-T2? So what they actually propose is that we look into the characteristics, the molecular mechanisms and biomarkers and the natural history itself. So objectively, what we should do is actually look into the biomarkers. Later on, I will show you. But how about patient-related? If we have all this, are we sure that this patient we are labeling as severe asthma is severe asthma? And honestly to tell you, some of them has poor adherence to treatment. And when you can see lots, and this is one of the papers from our Malaysian counterparts, they're looking at patients, when they feel they are controlled, they stop their medications or they take it as PRM basis as such because they feel they're well. So it's more than nearly about 40% of patients do not really take their proper inhalers properly. And patients who are difficult to treat asthma, if you can see, they are non-adherents. Confirmed non-adherence about patients quite high in the sense that you can see from your left, about 69% of patients who are non-adherents when they presented in ERS 2018. They were difficult to treat asthma and they were non-adherents. And most of them, possible non-adherence and unknown adherence. So this group of patients, do we put them as severe asthma or it's just difficult to treat asthma? So incorrect inhaler technique, you can see from here, prevalence, meaning a significant proportion of patients with difficult to control asthma remains non-adherent to corticosteroid therapy, and the mishandling remains a real control associated with reduced disease control, which you can see from here is that inhaler mishandling continues to be common in experienced outpatients referring to chest clinics and associated with increased unscheduled healthcare resource use of poor clinical control. And from here, there was a study actually done from a multinational survey of patients from 8 Asia Pacific countries, including Hong Kong and India as well. Patients who use types of controllers medication use, you can see that patients still use the pills and they prefer the pills compared to inhalers. So from here, you can notice that patients do not really adhere to medications, which is inhalers, which is, I think, common in every country globally. All right. So how about assessing the biomarkers again? Let me go a bit there. So from here, you can see from GINA guideline that they actually looked into how objectively to look into the phenotypes, as we have already investigated the comorbidities and so on. What you should do is actually looking into the serum immunoglobulin E, looking at patients with blood eosinophils, sputum eosinophils. Yes, it is actually suggested, but I think we do not do that because it's very difficult to do and not all centers use it. And usually it is actually looking into other things like skin prick tests and specific IgE as well. All right. So at this time, you need to consider as well the psychosocial, and we need to involve the multidisciplinary. And if we do have registry, it will be good to actually enroll patients with registry or clinical trials if available. So these are the phenotypes objectively how you actually test. Which the eosinophils, you can either test via blood or sputum, IgE. And it is suggested periostin and pheno. But what do we have available? Honestly, to tell you, in Malaysia, we can only do eosinophils, serum eosinophils, not sputum. We can actually do serum IgE and specific IgE, and we can actually look into the pheno. Otherwise, everything else, it is not really accessible to every state in Malaysia. And what we found from this study that in 2021 by Singh et al., pulmonologists and allergists, actually what influenced the therapy decisions, it is not really the biomarkers. And honestly, even we as clinicians, we know that these biomarkers help us, but the most important thing is the history itself. Hospitalization, ED, OCS burst, and as well as lung function tests. So less than 30% of correspondents felt consideration of biomarkers for therapy decisions was important of highly importance. And to top it up, in real life, realistically, the T2 biomarkers, numbers of blood eosinophils depends on OCS, ICS. It can actually differ. Time of the last allergen exposure, if the patient had let's say an influenza infection. So it might actually differ. It might be due a concomitant disease such as infection and CTD. And even the levels of pheno is not really accurate. It depends on the ICS use, but also all OCS use, and depends on a patient influenced by other inhaled agents. And if the patient has increased, and it's also increased by other atopic diseases. So how about treatment related in inadequate dose or schedule, inadequate services, and high limited resources? So this is GINA. What they actually suggest is that if a patient has type 2 airway inflammation and meet one or more of the following criteria on high dose ICS, actually should be started on biologic. Eosinophils more than 150 cells, pheno more than 20, sputum more than 2%, and asthma clinical allergen driven and need of maintenance OCS. As you can see, what are the things that you can start? IgE when the patient is more than 6 years, severe allergic asthma, and the patient has a total IgE increase of total IgE and weight and sensitization as skin prick test. If you want the patients to be started on anti-IL-5 or anti-IL-5R, the patient should be age of 12, more than 12 or more than 18, with severe eosinophilic asthma, with having exacerbation in the last year, and blood eosinophils more than 300. And the start of, if you want to start off anti-IL-4, the patient should be more than 12 years old with severe eosinophil asthma or need of maintenance OCS. Exacerbation in the last year, eosinophils more than 150 and FeNO more than 25. So if, let's say, you start this, what are the predictors? Can we actually look into the predictors? Is there any objective way to predict good response? Starting IgE, usually you will need a blood eosinophils more than 260, FeNO more than 20, allergen-driven asthma. And the predictors of good response for IL-5 is high blood eosinophils, exacerbation in the previous year, onset of asthma, and nasal polyp. And if starting off anti-IL-4, predictors should be more higher of high blood eosinophils and higher FeNO, and may be used to treat severe atopic dermatitis and nasal polyps. So this is actually a very nice way presented in the Journal of Allergy Clinical Immunology 2022 of how you would actually start a biologic, meaning confirming presence of severe asthma, establish the blood eosinophils and FeNO levels, and validate eosinophil levels by reviewing history, meaning that we do not look at that current results, but looking at previous and performing repeat measures and confirming presence of T2 and comorbid disease entities associated with severe asthma. And biomarkers and comorbid entities associated with severe asthma should be considered as well. And so from here, it looks into how you would start is looking into looking at eosinophils first and look at FeNO. And later on, they actually suggest on which of anti-IgE, anti-IL-4 or anti-IL-5 in patients. Okay. So in spite of this, all right, I'm just going to give you something that I found in the papers, attitude and perception of asthma in treatment. So patients, complete control, they presume, looking at this, in Malaysia, about 6% was controlled. And they felt they were controlled. And partly controlled about 63, and uncontrolled was 30. And looking at India itself, nearly the same. The control in Malaysia, I am not really certain, is this overly diagnosed or underdiagnosed, or India is actually underdiagnosing themselves. But I feel that overall it's nearly the same in all the countries in Asia Pacific. So looking, where does all these biologics target in a cartoon way? These are the biologics that actually helps in the pathophysiology and in patients like interleukin-5, mepolizumab, benralizumab, there's omalizumab, as well as dupilumab. So which one to consider starting first? The first thing you have to understand, I put it as first on top. Does the patient satisfy local payer eligibility criteria? Like in Malaysia, if that medication, that biologic is already in our formulary, in our medical Malaysian of health, and the patient is a government servant, they are likely to have a higher chance of getting the medication as well. And as well if they are a pensioner. Predictors of asthma response or type 2 comorbidities such as atopic dermatitis, nasal polyposis, or the patient preference, because you have to understand, some would have every 2 weekly, and there are which you can give actually every 2 months. The most important thing is the cost, the frequency of dosing, delivery of route, which is IV or subcutaneous, which patients have the potential of self-administration. And this is a very interesting paper that I found, just released in 2023. The reason behind Indian patients opting out for therapy of biologic agents. And you can see that even though this is the medication that everybody says is the medication, but you have to understand the patient is always right, and the patient has its preference. And looking at this, usually why the reasons they opt out from therapy is that they have optimal asthma control in spite of that. And they feel that the length of therapy is too long but the most important part is the economic constraint. And I think it echoes to other parts of the world as well. So when you want to actually consider biologics, you have to look at the age, the outcome desired. What are you actually hoping for? What is your objective of treatment? The frequency and the ease of administration, the concomitant allergic state, and the economic concentration, which is very important. Actually summarizes everything what I'll be talking today. So this is actually the algorithm which was actually presented in New England Journal in 2022, whereby after you have started on a biologic and when you would consider the response and would you feel that you will reach to a remission or need to change to a biologic if it's not controlled. So these are again, the biologics that which the FDA United States have approved, starting from omalizumab, mepolizumab, resilizumab, Benra, and later on the latest, the nuclear block is tezepelumab. But resilizumab we do not have. Mepolizumab also we do not have in Malaysia. Tezepelumab has not reached Malaysia yet. So these are the three that has is in Malaysia, but the only one that is in our formulary, current formulary, is omalizumab, which is in our Malaysia of Health formulary. So when you look into all these biologics, you can see that I just want to give you at the end there what it is, the frequency. So omalizumab is every 2 weeks, or it is shown that in Articaria you can give every month. Mepolizumab is every month. Resilizumab is every month, but it is in IV. Benralizumab, the first few injections will be every 4 weeks. Later will be every 8 weeks. And dupilumab every 2 weeks. And tezepelumab, it is actually the first. It is also 2 weeks, every 2 weeks, and later on every 4 weeks. So just very briefly on each biologics. Omalizumab, the oldest biologics of all, more than 20 years. It actually reduces the free serum IgE for more than 95%. And it has usually for patients with asthma uncontrolled, despite of high dose ICS LABA, and who are adherent to therapy and demonstrate good inhaler technique. So from data, it shows that it has reduced significant exacerbation in multiple studies. And how about IL-5? It's actually a monoclonal anti-IL-5, monoclonal antibody aimed to inhibit eosinophil function. And you can see that benralizumab targets and blocks interleukin-5 R alpha. Why I'm just looking at Benra? Because the other two is actually not available here, but I will just go briefly on mepolizumab later. So mepolizumab is actually selective, inhibits eosinophil inflammation, and it may lead to reduction of exacerbation and need of treatment of systemic corticosteroids. So it is actually approved as an add-on maintenance therapy for severe eosinophils, severe asthma. And you can see from here that studies have shown that it has reduced the exacerbation and increase in lung function tests and increase in quality of life from this paper. It also has a good oral corticospastic effect with reduction of glucocorticoid dose and 32% reduction of our rate exacerbation, right? Benralizumab is actually, again, anti-IL-5R, and it has actually proven in a lot of their studies, Sirocco, Kalima, Zonda, Bora, maintain with patients who are more than 12 years old with severe eosinophilic asthma. And the good thing about Benra is subcutaneous, and it can be given every 4 weeks and later on every 8 weeks. This is the good point about it, and it's a selling point. But otherwise, honestly, it has its efficacy. It has shown that it has reduced in eosinophils as well, and annual acute exacerbation rate, and with increase in lung function tests. And it also has a sub-analysis suggesting oral corticosteroids and nasal polyps so associated with the increased response. And it has actually shown that it can reduce oral corticosteroids usage very very significant with a p-value of 0.01. And this has been shown that even patients who were started on bevacizumab, eosinophils can actually go down to up to 0. How about dupilumab? It's actually a fully human monoclonal antibody targeting IL-4 and IL-13 receptors. And it actually demonstrates decrease in exacerbation, reduced steroids dose. And it is also a selling point which actually has approved add-on maintenance therapy for patients more than 6 years old and with moderate to severe eosinophils or oral corticosteroids asthma. All right. So from here, you can see that it has shown that it reduces exacerbation significantly compared to placebo. And it also has shown that it increases the quality of life. And the best thing about dupilumab is that it's an objective way of assessing it is the FeNO. All right. How about steroid dependent? It has also been shown that it reduces the steroid dependence, and the patients noted to have remarked steroid reduction usage in patients. All right. Looking at all this, knowing omalizumab has its about more than 20 years, how about long-term treatment in biologics? So there are a lot of papers now coming out, but I'm just giving you some which is showing that long-term biologic treatment. Looking at omalizumab, this study actually shown about 5 years trial. So it has sustained response in increase in ACT score up till the end of the study and towards 0 hospitalization. And it actually shows almost 0% patient undergo any asthma-related hospitalization at the end of the 5 years. And this is actually remarkable. So all these things, more than system evaluate, summarize outcome initiation of omalizumab using period of more than 48 weeks, asthma control significantly increase, improvement of quality of life, and reduction of OCS consumption, and reducing the steroid-related side effects, and reduction in healthcare resource utilization, and reduction of hospitalization ED visits in patients who are on omalizumab. And the best thing about this systemic review is that we found that there was shown about 9 years, and the difference from baseline was excellent. Okay, how about loss of cessation? Okay, this is interesting in the sense that patients who have been stopped of omalizumab, you can see that there are a few patients that actually had quality of life after. There are some that patient actually increase in quality of life, but there are patients who actually loss of asthma control. So meaning, are we going to give them for lifelong? Something that we need to ponder in that. How about benralizumab? There was actually integrated analysis of study, which is MELTAMI. They look into all the studies that are done under benralizumab, Sirocco, Kalima, Zonda. And they found that after 48 weeks, after up to 5 years, integrated about 5 years, they noted that there was actually a reduction in exacerbation, and it shown that the profile was consistent with the predecessor studies, and the patient had no new safety signals or no death on the on-treatment window. So patient had actually 75% of them had 0 annual exacerbation, and patient was well. Okay. And the latest from ERS was a Sharma study looking at patient on benralizumab. What we found was that in patient on prolonged benralizumab, noted that patients were able to reduce their usage of inhaled corticosteroids, and some actually had not requiring at all, only anti-inflammatory reliever only. So in this group of patients, showing that patients became very well after started on benralizumab. All right. And you can see from here the total ICS dose was significantly lower in treatment reduction arm at week 32, and the patient treatment reduction arm used about 73 less of ICS compared to the reference arm, meaning they were able to reduce, because when we talk about systemic corticosteroids, we know all the side effects. But now we are looking into patients who are using high dose of inhaled corticosteroids also are not a group of patients that we should forget the side effects of corticosteroids itself. So last but not least, this is a very busy slide, but looking of biologics for severe asthma, which, when, and why. Later on, you can see that what is the predictors, what is the eligibility, and what is the expected outcomes. Most of them, what we want for the outcomes is actually reduction of exacerbation, increase in quality of life, and increase of lung function, as well as OCS reduction. All right. And what they found was that when they did impact of initiating biologics in patients with severe asthma, long-term oral corticosteroids in patient, glitter study actually extracted from the ISAR, they noticed that patients that were initiated, the patients had remarkably all reduced exacerbation rate, asthma ED visits and hospital visits, and the asthma control was much improved. So, to end my talk is that looking at the challenges is not just the patient, not just the doctor, but you have to look at the whole set as a whole. Patients, if looking at the health professionals, we tend to have poor communication, and we do have time control in each patient, poor adherence to the guideline itself, and we have lack of standardized referral pathways, suboptimal use of spirometry, definitely, suboptimal use of assessment tools, inconsistent approach of diagnosis and treatment, which is underdiagnosed or undertreated. And we hope that from there we can actually develop and implement training program, and we hope from both countries we can actually co-manage and have a lot of MDTs together, management of algorithm, referral guidelines pathway, and patient-centered care approach, and implementation research, and increase in telehealth update. How about patients? We know that poor patient-physicians communication, perceptions, and treatment costs. And this one will need patients. We have to have provision of patient advocate, enhance our effective self-managing skills, and questionnaires for feedback. And most of all, we need to actually give awareness to our policymakers, the healthcare system, which we actually lack of fund and multidisciplinary team, complexity of the biologic accessibility, and inequitable access to specialist care, and geographical barriers, and lack of accessible biomarkers. And we hope that from there we can have registries and to show proof that we need to improve our health economics assessment, research, and policy framework, and share care models. So last but not least, we need to look all this: non-allergic triggers, anxiety, untrained multitasking staff, limited treatment option, assessment barriers, accessibilities, high limited treatment costs, and especially the pandemic, which is not really going away. And this is I just put the, November 20, I didn't put the 2022. We have our own Malaysian Thoracic Society referral checklist that we try to implement, and still ongoing, for primary care to actually refer to us in severe asthma clinic. So we hope that helping one person might not change the whole world, but you really could change the world of one person. With that, I thank you. Any questions? We will have a group panelists to help to answer all your inquiries.
So thank you to both our speakers for the enlightening talk. Now we move on to the next session, which is a discussion moderated by my counterpart, Prof. Sundip Salvi, the president of Indian Chest Society.
After two very beautiful talks by Dr. Azza Omar and Dr. Rajadhar from Malaysia and India, We will now start with the panel discussion to gain some more insight into the changing paradigms of asthma and what does it actually mean in your clinical practice. I am Dr. Sandeep Salvi. I am the president of the Indian Chest Society, and it is indeed an honor and a privilege to be partnering with the Malaysian Thoracic Society for this educational webinar. We are very grateful to Dr. Ismail, the president of the Malaysian Thoracic Society, and his team to support this event. We have two panelists from Malaysia who are going to share their experience and their knowledge base with us. Dr. Azza Omar, who is one of the senior pulmonologists in Malaysia. She's responsible for developing the Malaysian CPG asthma and is actively involved both in the Malaysian Thoracic Society as well as the Malaysian Association of Bronchology and Interventional Bronchology and Interventional Pulmonology. So welcome, Dr. Azza Omar. The second panelist from Malaysia is Dr. Professor Andrea Ban Yulin, who is from the University of Kebangsaan in Malaysia. And she has also had a special interest in the diagnosis and management of asthma and has been contributing immensely in this field for the Malaysian Thoracic Society. On the Indian side, we have Dr. D.J. Christopher, who has been the past president of the Indian Chest Society, has also been the professor and head Department of Respiratory Medicine at the Christian Medical College in Vellore, one of the premier medical schools in India. Dr. Christopher has contributed immensely to the field of respiratory medicine in India. He has had varied interests in the specialty of respiratory medicine, starting from the obstructive airway diseases like asthma and COPD, but also has a lot of interest in tuberculosis and interventional pulmonology. The second panelist from India is Dr. Nagarjuna Mathuru, who is one of the young and dynamic young pulmonologists of India. He is based in the city of Hyderabad and is the head of the Department of Pulmonology in one of the premier corporate hospitals in Hyderabad. So wish you a warm welcome to all the four panelists, and I really look forward to listening to your experiences and your advice for practitioners who have joined today, who are dealing with patients with asthma in their practice. So to kickstart, maybe we can start with the Malaysian group. We can start with Dr. Azza Omar. What is your overall perception about asthma in Malaysia? Has it remained static? Has it been growing in Malaysia, or you see a downhill trend in the prevalence and burden of asthma?
Thank you, Prof.
Dr. Azza Omar.
Thank you. Thank you so much, Prof. Sandeep. First and foremost, I should be thankful that we are collaborating and we are actually joining a lot of things together. In Malaysia, actually, as you can see, I think it's nearly the same as other parts of Asia. The first thing is that we are seeing that asthma is now becoming more profound in the sense that people are getting to know and aware of asthma itself. But in 2017, Global Can actually just stated Malaysia as about 4.7%. But in the future, that in the papers that we are seeing in our local papers, is actually increasing. And what we worry is that now we are looking into the primary care. There was a few papers actually presented in our local setup that is actually looking into the uncontrolled group of patients, and it's about covering about 20 to 30% of that population. And this is actually relevant and it mirrors actually most of the other countries that we see. Hoping that, and it is now we are looking into the perceptions of the physicians now, which is now looking into new therapies and immunomodulatory therapies. And we hope that in the future that we can actually target more specific in asthma treatment in the future.
Thank you, Dr. Omar. Dr. Christopher, what is your overall perception about asthma in India?
Thank you, Sandeep, for asking me this question. I have been managing asthma since the late 80s. That's going back a long time. My sense is that from then there's been a steep increase in asthma, and that continued to be at least till a decade ago. Whether it is still continuing to increase, I do not know. Now, having said that, this is anecdotal. How much of this is due to actual increase in disease and how much of this is due to more awareness among physicians and being able to diagnose asthma is the conundrum that we need to decipher. So, is asthma increasing? Well, asthma certainly has increased, but whether it's still increasing and continues to do so, we cannot say with precision. We unfortunately miss authentic, good research studies, which are certainly the need of our country. Perhaps Malaysia has slightly better epidemiological data than we have, but that is the question. But what is clear is that there is increased awareness among physicians, not just respiratory and asthma specialists, but also among general physicians, pediatricians, general practitioners of asthma, and there is less reluctance to diagnose asthma. Earlier, there was a reluctance to put a tag of asthma. They would even go to the point of saying allergic bronchitis, eosinophilic lung disease, things like that. But they would not place a diagnosis of asthma. But that is changing, and I think that's progress.
Yeah, thank you, Dr. Christopher. I think one very important point you mentioned, especially from an Indian perspective, is the stigma that is associated with asthma. People do not like to be labeled as having asthma for various reasons. And this has been a real challenge, especially in the Southeast Asian countries, where we probably have seen a significant increase in the burden of asthma. I mean, they think the numbers are growing. You're very right, Dr. Christopher, whether this is a genuine increase or whether this is increased awareness, we're not very sure. But coming to this point of a social stigma, Dr. Andrea, in Malaysia, how do people look at asthma? Is there a lot of stigma associated with it? There are misbeliefs associated with the disease, and how do the physicians actually tackle all this?
It's a very good question, and the answer is not simple. I think there is still a stigma associated with asthma, and there's always the worry about being hooked on to inhaled corticosteroids. So whenever we label someone with asthma and we initiate therapy, especially inhalers, along the way, the question would be, when can we stop the inhalers? And there's always this slight reluctance. So either you sense it or if you ask them and they're quite open, they will tell you point blank that the reason why they do not become compliant to the inhalers is because they're worried that they will actually be, for example, addicted to it. So that's their very word for it. So in terms of stigma per se, I think that probably asthma is a little bit more fashionable to use. So a lot of COPD patients are also labeled as asthma. And we do get a little bit of overdiagnosis of asthma from patients who are actually admitted from the emergency department. So you get them labeled as exacerbation of asthma when actually it might be something else. So I think the one airway, because you know that there are many factors that contribute to the symptoms that may mimic asthma. So that would be our problem. In terms of diagnosis part, I think there shouldn't be a real issue because we actually do run the spirometry course by MTS. So we have actually probably trickled down the information that spirometry is actually an important tool to diagnose asthma, and it should not be based solely on a clinical history.
Yeah, thank you so much, Dr. Andrea. That was a brilliant answer. Dr. Nagarjuna, in your opinion, do you believe that in Southeast Asian countries like India and Malaysia, air pollution has now become an important contributor to the risk of developing asthma. We know that asthma is a very, very strong genetic disease, but the environmental factors are also equally important. So, do you believe that air pollution is contributing to the so-called growing burden of asthma in India and Malaysia?
So I think I would say, at least in our country, definitely yes. So I think both in the urban as well as in the rural areas, the pollution levels are beyond what it has to be, and definitely I can say that, see, both to the incidence as well as the exacerbations. So the increasing air pollution leads to more number of people developing asthma, as well as asthmatics developing exacerbations and losing their control. So we see a lot of people who come from villages to the metro cities, and then suddenly they become symptomatic. They start having poor control of asthma. They start having exacerbations. So I think definitely in the current generation, yes, both indoor as well as outdoor air pollution, I think, have to be pictured in whenever we take history from a patient with asthma or
Yeah,
asthmatics.
thank you, Dr. Nagarjuna. Dr. Christopher, the Western world has emphasized a lot of role for allergens or allergy in the pathophysiology of asthma. And in fact, when you do a workup for asthma in the Western world, they will always look for allergens and they'll do skin prick test and other forms of allergy testing. How relevant do you think that is for countries like India and Malaysia? And would you recommend that all asthma patients should specifically be examined or tested for various allergens? And do you routinely do allergen skin testing in your practice for asthma?
Okay. So I will start from the end, so you know where I am coming from. So we do tests for our patients, most of them, that, for us to know if they are atopic asthmatics or non-atopic asthmatics, it just gives us a sense of direction of how we manage them and what we can expect. And of course, going forwards, when we talk about the biologics and other immunologic treatments, understanding where they come in, whether their allergy is IgE driven, eosinophil driven, or neutrophil driven, all this becomes important. So if you look at it from the evolution perspective, allergy testing evolved as a simple test that allergists used very freely, and they phenotype the patients based on the allergy tests. But I concur with your concern. So one of the things that we lack is standardized allergens. There are so many different types of allergens in the market, and there is difference. Now, I am not saying this anecdotally. One of the studies we did was to compare international standard allergen with allergens available in the Indian market. We used house dust, and we found that the wheel that we raised with the allergen was 10 times weaker with the Indian allergens. So there was so much variation between the international standard and the Indian allergens, and even between the Indian allergens, there were differences. So there are concerns about freely using them because of lack of benchmark and standards. But otherwise, allergy testing is a proven modality for analysis from an allergy perspective.
Thank you, Dr. Christopher. Dr. Azza, in Malaysia, do you routinely perform allergy testing in your asthma patients, and how does it impact your course of treatment?
Thank you, Prof. Listening to Dr. Christopher, I'm quite wowed by that. In Malaysia, we are not that as lucky as that, because testing for all these allergens is actually being part of testing for patients who are with uncontrolled asthma or severe asthma. We do not do that routinely. because in the sense that I think one is we do not have the expertise. Most of us are not really really expert on this one. And the second is that most of us are focusing on actually in the treatment of asthma per se initial phase. So testing allergen is mostly being part of one of the testing for severe asthma. And I think I agree with Dr. Christopher. It's just that the allergens from the Western countries may differ from us in Asian countries, but that is yet to be proven in our part of the country. The other part is that for us is actually to identify patients with more of other comorbids, which we can actually address. It's much more easier for us to actually treat the patient.
Good, very good. Thank you. Dr. Andrea, to diagnose asthma, we rely a lot on clinical history because I think that's the major clue towards the diagnosis. But sometimes it's also very important to do objective diagnosis. How common is spirometry performed in Malaysia for the diagnosis of asthma?
Okay, so as Dr. Izwan, as Prof. Izwan mentioned earlier, I work in the university-based teaching hospital. So in our center, we actually have spirometries, and there are spirometries available in other hospitals in the Ministry of Health. So I think one of our aims, correct me if I'm wrong, Azhar, is that we should make spirometry readily available. This is our aim, that it should be as it should be like an ECG, meaning that if you've got a chest pain, you do an ECG. So if you have a cough, you should actually have access to spirometry, so that you are able to actually at least look at your lung function at a glance and to see very obviously if you actually have an obstructive picture and whether it's reversible. So yes, our smaller clinics also have access, but not all of them. And we do get referrals from GPs and from other centers with the diagnosis of to rule out asthma, and this is when we actually perform spirometry. So in terms of because we are from a teaching hospital, so we do place a lot of emphasis on the history, and this is what we teach our students, that they should not run away from the history, because occasionally in just that one day that you actually do a spirometry and you don't find a reversibility, that doesn't mean that the patient doesn't have asthma, because there's a diurnal variation as well. So there are many other modalities that is advocated by GINA. And in Malaysia, we are proud to say that we also have access to FeNO, fractional oxate nitric oxide. And in another center in the Klang Valley, we also have methacholine challenge test. Not in all centers, but you don't need it in many centers because it's not routinely done. It's actually done when you have exhausted your more common investigations. So in certain centers, like in the CPG, Dr. Azhar and I in it, what we did was we also mentioned that you may actually use the peak expiratory flow rate as an alternative to spirometry if you don't have access to it, to actually look at the diurnal variation. So that will aid you to coming to the diagnosis of asthma.
Thank you. Dr. Nagarjuna, you work in a corporate setting and in one of the premier hospitals in our country. What are the tools that you use in your practice to diagnose asthma? And which ones do you believe are the ones that genuinely help you in confirming the diagnosis and initiating treatment?
So I think I would partly agree with Dr. Andrea that spirometry and clinical history, these two are the things which help us maximum. So if you're able to prove a reversible airflow obstruction in a person with a history of suggestive of asthma, then that is very clear. But then that forms only a subset of people whom we eventually label as asthma. So in such cases, ideally, GINA says you have to do a bronchial provocation test and then prove airway hyperresponsiveness. But unfortunately, it is not there even at our center. And we all know that except a couple of centers in India, there is lack of access to this methacholine. So in our center also, despite the fact that we have almost everything with us, to label a person as asthma, we resort to one, spirometry, two, clinical history, And the two other tests which we also do are, one is pheno and oscillometry. I would not say that either positive pheno or positive oscillometry in isolation would help us labeling a person as asthmatic, but in the overall clinical context, if you have a person who were not able to prove reversible airflow obstruction but has a high pheno in a compatible clinical setting, that would help us in probably labeling him as asthma. The other thing which we now, the last couple of years, have routinely started using is oscillometry. So impulse oscillometry also sometimes can pick up this small airway disease in cases where spirometry is normal. So that is something which we have started to do, but I think it has not yet come into the guidelines, but that is something which we have started following.
Okay. Okay. Thank you, Dr. Nagarjuna. One very important point that I wanted to raise in this discussion is the use of short-acting beta agonists in the treatment of asthma. If you look at it from a historical perspective, I think short-acting beta agonists have been saviors for asthma patients because it relieves their symptoms almost within 5 minutes. So a lot of short-acting beta agonists is widely used in the management of asthma. And one of the biggest changes that has occurred in recent past in the Global Initiative for Asthma Strategy Report is patients of asthma should not be given only short-acting beta agonists. Every patient of asthma, be it mild intermittent, mild persistent, and all other severe grades, must receive an inhaled corticosteroid. I think that has been a very, very big change in the diagnostic strategy of asthma patients. Despite this, a lot of asthma patients still continue to use only a short-acting beta agonist. And I think that's a big problem. So I'm going to ask Dr. Christopher first and then Dr. Azza. Do you genuinely believe that short-acting beta agonists are overprescribed and they are a problem because these patients they do not use inhaled corticosteroids, and that is contributing to the suffering and the deaths that are associated with asthma? So Dr. Christopher and then Dr. Azza.
Yeah. So Sandeep, I watched short-acting beta agonists, the entire cycle of its evolution. So when I started practice, people were predominantly given oral beta agonists. Salbutamol was given as tablets. Of course, then inhalers came and all the taboos of inhalers also came with it. But gradually, people kind of got used to it, and inhaled salbutamol was available. Now then came inhaled corticosteroids. And so these were the two things, regular inhaled corticosteroids as needed, short-acting beta agonists. There was a study that looked at regular use of short-acting beta agonists. You would think that if you give the short-acting beta agonist 4 times a day, then you would give them round-the-clock bronchodilation. But the study results were surprising. It actually showed that people who used regular SABA had worse control than people who used as required SABA. So the hypothesis that was put forward to explain this is that, this suppresses the inflammation by bronchodilation, and they don't take enough of inhaled corticosteroids. So short-acting beta agonists only as required, and ICS only should be taken twice a day regularly. And then the LABAs came. The LABA ICS became the cornerstone of asthma management in many ways. And then we came to regular use of ICS LABA and as required ICS LABA combination. So we used for control as well as for relief the same inhaler. Then I think there are studies that now show if you give short-acting beta agonist, there again it has to be combined with steroids. So we have come a full circle, and the take-home message really, as I see it, Sandeep, is that anti-inflammatory treatments are the backbone of asthma management. So if any treatment misleads us in giving less anti-inflammatories, then the patient is in trouble. So the bronchodilating drugs are complementary, but we should not let them mislead us in giving less anti-inflammatory drugs. Thank you.
Yeah, thank you, Dr. Christopher. Dr. Azza, if you use your short-acting bronchodilator drugs, if you use more than 3 canisters in a year, that is considered to be overuse of SABA. And the Sabina 3 study from Malaysia did show that around 40% of asthma patients in Malaysia continue to use only short-acting beta agonists or predominantly short-acting beta agonists in asthma management. Is that a problem, and what is the key message that you would like to deliver to the doctors who are attending this program? What is the key message you want to give them?
Yes, thank you, Prof. The thing is that the awareness, that's the first word, awareness. But the thing why patients love to use this blue puff is just because of the fast symptom relief. The understanding that we need to understand is that when you look into studies, even the physicians themselves do not actually advocate this part of awareness, meaning what is the pathophysiology behind the asthma itself. The pathophysiology itself is actually inflammation, and we need inhaled corticosteroids. But the thing is that is something like most of patients do not understand. They will say that they took the brown puff, it doesn't work, and when they take the blue puff, it works. So that it comes to the most important part is awareness, education, both to physician itself and to the patient. And this is very alarming in the sense that, yes, we come from the tertiary center, we try our best, but once the patient comes to us, it's already in the late phase and they come in the step 4, step 5. But what we are actually lacking in this is that I think it doesn't really say Malaysia itself. I think most when I meet up with other counterparts in other parts of the country, in other parts of the world, even in Western countries, it's still a burden that they see that patients do not become aware of what is the underlying problem in them. So for me, yes, it's really a challenge for us, we as chest physicians, to actually advocate and try to give this knowledge to our new doctors as well as the new, especially in the rural areas, that it is the SABAs actually only is just a reliever, but it does not actually target what is the underlying cause of this problem. And it's going to be a vicious cycle in the end.
Yes, Dr. Azza. So a key message that I would like to deliver to all the attending physicians is, do not treat asthma only with a short-acting bronchodilator.
Correct.
It will give them immediate relief, but in the long run, it will cause them more suffering and increased risk of dying. So no asthma patient must be denied an inhaled corticosteroid. Even if it is mild intermittent, even if your asthma patient has symptoms once, twice, thrice in a month, I think it is imperative to give them an inhaled corticosteroid whenever you're giving a short-acting beta agonist. I think that is the new knowledge that we have earned, and it is very important to follow that. We have another 5 minutes, and I would really like quick, short answers for this so that we can cover a few more points. Dr. Andrea and Dr. Nagarjuna, biologicals and other immunologicals in the treatment of asthma, use of bronchial thermoplasty. There's so many new tools, new therapeutic tools that have come out for asthma management. How common is it used in Malaysia, and what is your impression about the efficacy of these biologicals and bronchial thermoplasty and other immunologicals that are used? Dr. Andrea, please first.
Okay, thank you. Short and sweet, I think. So we do have access to biologics in Malaysia, and I think Dr. Azza is one of the centers that uses the most biologics. We hope to catch up with her soon. We also have access to bronchial thermoplasty. Again, not in all centers, just in one. You might have heard of him. Dr. Jamalul actually does bronchial thermoplasty in Hospital Serdang. So I think data for bronchial thermoplasty from the Cochrane review, there is no long-term, they need to have longer studies for it. So I think probably this is not quite I'm not the expert in it, but I do have experience in biologics. And I think the exciting thing for patients who've got severe asthma, again, it's only about 3%. So we really have to look hard for patients who've got asthma. I don't think that someone who is actually uncontrolled should be wrongly labeled very easily as severe asthma. But once you actually phenotype the patient with the investigations as per the GINA guidelines, when you treat them, it is very rewarding. The patients will be very happy with your care, and they can return to normality in life. So we've had patients who've actually they can go back to work. There was a patient who actually lost her job because she couldn't work. When she was started on biologics, she felt much better, and she could continue to earn her living. And she's like a middle-aged lady. So I think, and the promise of biologics is actually the return of normality to patients who were previously left with a very large dose of continuous dose of oral corticosteroids and suffering as a consequence of it from all the bad side effects.
Yeah, Dr. Nagarjuna, a quick answer.
Yes.
What proportion of asthmatics do you use biologicals, and how effective is it?
Indians, yes, I think the scope for biologics in India is really huge because of the population. And even though I would say that less than 1% of them would actually need a biologic. So you have to be very, very meticulous when you want to use a biologic. You just cannot give it for any uncontrolled asthma who's coming for you for the first time. You have to do your homework, follow the stepwise protocol, confirm the diagnosis, check the nail adherence technique, rule out comorbidities, treat them, look for triggers, rule out ABPA. Then you phenotype and then give. But despite doing all of these things, in our severe asthma clinic, use of biologics is very common, and I would say it is increasing now. Now, a couple of things which I want to say: the number of people who are actually eligible for biologic and who actually end up taking biologic, still there is a disparity. And the main reason being the cost. So I think India is a very cost-driven market. Most of them pay from their own pocket. So I think still there is a lot to go as far as the affordability of biologics is there in our country. How good are they? If you're choosing a patient correctly, then I'm very sure they will work. It's all about choosing the correct person. So if you choose a T2 high eosinophilic asthma for an anti-eosinophilic biologic, there is an 80% chance that he would actually benefit from the biologic. Similarly, if you choose a correct atopic phenotype person for omalizumab, definitely it would work. So it's all about choosing the correct person. Last comment about thermoplasty. Yes, we have done the large number of thermoplasties, but with the advent of biologics, so when thermoplasty came, we had only omalizumab. We didn't have Mepoli and Benrali. Then came Mepoli, then came Benrali, and now thermoplasty is on the way out. So with the advent of biologics, people are more comfortable using these biologics. And in the couple of years, you're going to get dupilumab, tezepelumab. So I think the role for thermoplasty has significantly gone down to an absolutely small percentage who would probably fail biologic or who don't want biologics for whatever reason. So nowadays, in a year, we're doing only 2 or 3 people thermoplasty. So on the other hand, we give the biologics for maybe around 3 to 4 new patients every week. So I think that's a huge number of
Sure.
biologics we see.
Okay, thank you, Dr. Nagarjuna. We have literally 3 minutes, and I want 2 points to cover. Dr. Christopher, self-management apps, digital health. Do you think that the time has now come for utilizing digital applications for asthma management? Do you think there's a role for that?
There certainly is. Now, I think the one that was used extensively, not digital, but probably mechanical, is peak flow meter. So we have always used that to aid us in assessing control and appropriately treating them. So now with the advent of many digital technologies, we'll be able to do a lot of things. We would be able to track patients a lot. We would be able to see their compliance. We would be able to see their techniques. So a lot of things may become possible with technology. So I think this may all, I think hopefully be for the better, and it may help us manage patients better is what I think.
Very good. Dr. Azza, in Malaysia, you think there's an initiation of digital health health in asthma management?
I think it's something that in the future, yes, because our aim and our ministry is looking into all this digital and AI. But I think Malaysians to reach that point, is not in the real near future, but we hope we can get that.
Okay, so coming to the last point before we conclude, there is this new emerging phenotype of asthma called as SAD asthma, or small airways dysfunction related asthma. And recent studies have shown that up to 50% of patients who have asthma actually fall into this phenotype. And this is a very unique phenotype that manifests with a very classical, difficult to treat asthma, nighttime awakenings, asthma that is associated with obesity, asthma that is associated with exercise. And therefore, there is now a renewed drive to diagnose this phenotype of asthma, so small airways obstruction, either using spirometry, that is FEF 25 to 75, or oscillometry, is becoming more popular to pick up SAD asthma. We also have drugs that can potentially target the small airways, so ultrafine inhaled corticosteroids like the beclomethasone HFA formulation or the ciclesonide are the new ones. So quick answers, Dr. Andrea. Do you think that SAD asthma is going to be one of the important phenotypes of asthma that will merit attention, diagnosis, and treatment? And then Dr. Christopher.
Okay, thank you. I think small airway disease in terms of asthma has always been there. Perhaps we have not diagnosed it more, but I think with the advent of iOS in our center, we actually have iOS, and we do see that a proportion of patients who've got fairly normal spirometry go on to actually, when you see, have abnormal iOS indicating small airway disease. So we do see the signal that perhaps we were not looking hard enough for small airway disease, and now that it's fashionable, we look for it, but it shouldn't be that way. I think we should look for something to explain the patient's symptoms. So in terms of medication, yes, some of the smaller particles we have seen, and data also supports it, that the smaller particles do actually give us slightly better control in patients with presumed small airway disease.
Dr. Christopher, your final comment on this.
Yeah, this is a entity that I think we need to watch carefully. We classically believed that asthma was a disease of the large airways, and small airways perhaps didn't figure in asthma pathogenesis. But we now know that's not true. And we also know that focusing or providing medication that go to the small airway perhaps can give complementary benefit to the benefits they're already receiving with the conventional inhaled drugs. So to me, now the challenge with small airways is to detect and diagnose it. Spirometry, the MMEF is not a very robust parameter. FOT is very promising. People are doing a lot of studies on FOT. And well, probably imaging studies may be required to show. So it is a little challenging to detect, but this is an entity I think we should watch carefully and try and see if we can help patients who have exclusive small airway disease.
Yeah, thank you. Now we will come to last. So if you could just give one concluding statement, just one sentence. What is your final carry-home message? All these delegates who are listening to this are all practicing physicians dealing with asthma patients. What is a key message that you would like to give? Each one of you all can decide of one key message. I can start with Dr. Azza. What is your key carry-home message? Just one sentence, Dr. Azza.
Identify the correct phenotype and always make sure they all have inhaled corticosteroids in them.
Excellent. Dr. Nagarjuna.
I would say that we should all pledge to stop using SABA alone for any of our patients with asthma. I think that is the most important thing now.
Dr. Andrea.
I was going to say the same thing, so I'll change the catch line to say no to SABA monotherapy.
Thank you. Dr. Christopher, your last line. You're muted, Dr. Christopher.
looking at asthma as not one disease but a spectrum, to be aware that there are phenotypes of asthma. They both behave differently and may be differently amenable to treatment will be my take-home message.
Thank you. I think on this note, we will conclude with the very exciting panel discussion that we had. All the panelists have given such valuable pieces of information and advice that we can now start implementing in our practice straight away. Dr. Azza, thank you so much for your contribution to this. Dr. Andrea, Dr. Christopher, and Dr. Nagarjuna. I think it's been a real pleasure to share the dais with you and talk about this very important disease that sadly gets undiagnosed, untreated, wrongly diagnosed, and wrongly treated. So with this, we would conclude this panel discussion, and I would pass it on to the organizers. Thank you so much. Once again, thank you, Dr. Azza. I think it's been such a wonderful experience to be with you, and Dr. Andrea as well. I thank you on behalf of the Indian Chess Society for being a part of this, and of course our own Indian Chess Society stars, Dr. Christopher and Dr. Nagarjuna. So I think it's been a brilliant discussion. Lots of very valuable points that have been
Very
that have come out.
flowing discussion. Very
Yeah.
a lot of points there, sir.
Thank you very
you.
much. Have a
Bye-bye.
good evening.
Okay, bye-bye.
Thank you.